Clinical correlate, osteoporosis. In the anatomy lecture, the role of osteoclasts in the development of osteoporosis was discussed. Osteoclasts carry out bone resorption by breaking down bone matrix, leading to the release of calcium. Take a moment to read the following clinical vignette. This 66-year-old white female presents to the emergency department with severe pain in her left hip and limited mobility in her left lower extremity after a fall. She is unable to bear weight on her affected limb, as demonstrated by her inability to stand. She is 5 foot 4 inches tall and weighs 108 pounds. She has smoked half a pack of cigarettes per day for 35 years. When examined, her left lower extremity is externally rotated and appears to be shorter than the right one. These signs point to a possible fracture of the left hip, which is later confirmed by X-ray to be an intertrochanteric fracture. Intertrochanteric fractures occur on the proximal part of the femur, between the greater and lesser trochanter. They are the most common type of hip fracture and in general have a good prognosis in the absence of comorbidities. This patient will most likely need orthopedic surgery to place a permanent hip screw and plate. Although the patient's spine does not appear to be compromised, she will need imaging studies of her lumbar spine in order to rule out possible injury, as vertebral fractures are not always clinically obvious. The patient reports having slipped and denies dizziness or confusion before or after the fall. Falls are a major cause of morbidity and mortality in the elderly and must be investigated carefully. Despite the absence of neurologic findings or history of cardiovascular disease, these common causes of falls in the elderly should be ruled out in this patient. This elderly woman likely has bone fragility, as evidenced by a severe fracture resulting from a relatively minor trauma. For this reason, causes of metabolic bone disease must be investigated. Blood tests have been ordered, including a complete blood count and measurement of serum calcium, phosphorus, vitamin D, alkaline phosphatase, and parathyroid hormone, or PTH. These are within normal limits, making conditions such as hyperparathyroidism unlikely. In an absence of urinary symptoms and a known history, chronic kidney disease is also unlikely. Conditions such as metastatic disease of bone and multiple myeloma should be investigated as well. However, given the absence of specific signs and symptoms, malignancy-related bone disease is not likely in this case. The absence of fever and an abnormal white count points away from infectious etiologies such as osteomyelitis. This patient is a postmenopausal, underweight, white female with a history of smoking and a probable positive family history of osteoporosis in her mother. Given this patient's risk factors, the diagnosis of osteoporosis must be considered as the underlying cause of her hip fracture. What is the best screening test for this patient's underlying condition? This clinical correlate has 4 learning objectives. 1. Define osteoporosis. 2. Describe the pathogenesis of osteoporosis. 3. Discuss the diagnosis of osteoporosis. And 4. Review the treatment and prevention of osteoporosis. We will begin by defining osteoporosis as our first learning objective. Osteoporosis is a skeletal disorder characterized by decrease in bone mass and deterioration of the bone's microarchitecture in spite of normal bone mineralization. The resulting bone fragility leads to increased risk of fractures. Osteoporosis is the most common metabolic bone disorder in the United States. Decreased bone density is characteristic of the disease. In measuring bone density, the mean is considered to be the bone density of an average 30-year-old woman. A bone density of 2.5 or more standard deviations below the mean denotes the presence of osteoporosis. Now, by contrast, osteopenia is a condition of lower than normal bone density that can progress to osteoporosis. In osteopenia, bone density is between 1.5 to 2.5 standard deviations below the mean. Risk factors for osteoporosis include age, usually greater than 50, race, with whites and Asians being affected more than other races, and gender, with a female-to-male ratio of 4:1 overall. An important risk factor for osteoporosis is family history, in particular a history of maternal fractures. Other risk factors include a body weight below 126 pounds. Lifestyle factors such as smoking and alcohol consumption are also known to increase risk. Inactivity is a risk factor, as is strenuous exercise, which in extreme cases results in amenorrhea, such as in female athletes. Osteoporosis can be classified as primary or secondary. Primary or involutional osteoporosis has no identifiable underlying etiology. It can be further classified into type 1, or postmenopausal, and type 2, or senile osteoporosis. In type 1, or postmenopausal osteoporosis, estrogen deficiency causes accelerated bone loss. It occurs most commonly in women between ages 50 and 70. Type 2, or senile osteoporosis, is due to aging. It occurs in both men and women over age 70. By contrast, secondary osteoporosis is caused by an underlying disease, a deficiency state, or medication side effect, and can occur at any age. There are many conditions known to cause secondary osteoporosis. Congenital disorders such as cystic fibrosis, Marfan syndrome, and osteogenesis imperfecta. Endocrine conditions such as hyperparathyroidism and hyperthyroidism, adrenal insufficiency, Cushing syndrome, estrogen deficiency, and pregnancy. Hypogonadic states such as androgen insensitivity, premature menopause, Turner syndrome, and Klinefelter syndrome. Deficiency states such as calcium, magnesium, and vitamin D deficiency. Inflammatory bowel disease such as Crohn's disease may lead to malabsorption and deficiency states that may ultimately cause osteoporosis. Other forms of inflammatory disease linked to osteoporosis are ankylosing spondylitis and rheumatoid arthritis. Many drugs are associated with the development of osteoporosis. Corticosteroids are known to have dose-dependent adverse effects on bone metabolism that lead to osteoporosis with a high incidence of fractures. Other medications are anticonvulsants such as phenytoin and carbamazepine, the anticoagulant heparin, and the mood stabilizer lithium. Neoplastic causes of secondary osteoporosis include leukemia, multiple myeloma, and metastatic disease. Miscellaneous causes include weightlessness, alcoholism, emphysema, and end-stage renal disease. Let's turn our attention to our second learning objective and describe the pathogenesis of osteoporosis. As previously discussed, the pathogenesis of osteoporosis is multifactorial. However, in all types of osteoporosis, the common mechanism is an imbalance between the rates of bone synthesis and bone resorption. In order to understand the pathogenesis of osteoporosis, it is useful to review the metabolism of bone. Osteoblasts and osteoclasts are the main cells involved in bone remodeling, a process by which bone is continuously reshaped and replaced. Osteoblasts form new bone by secreting and mineralizing osteoid. Osteoclasts carry out bone resorption and release calcium into the blood. More than 99% of body calcium is stored in bone. Vitamin D is required for intestinal absorption of calcium. In cases of calcium deficiency, PTH stimulates the breakdown of bone by osteoclasts, leading to release of calcium into the bloodstream. PTH also increases the excretion of phosphorus in the kidney. Calcitonin is a hormone produced in the parafollicular cells of the thyroid. It opposes the actions of PTH, by inhibiting osteoclast activity, blocking calcium absorption in the gut, and blocking its reabsorption in the kidney, leading to increased calcium excretion. Where osteoblasts require months to synthesize bone, osteoclasts require only weeks to resorb it. For this reason, a decreased rate of bone formation or an increased rate of bone resorption causing an imbalance in bone remodeling will ultimately lead to bone loss. Both mechanisms are involved in the development of osteoporosis. A third proposed mechanism of osteoporosis is decreased peak bone mass, which is reached at age 25 and is genetically determined in each individual. For this reason, a family history of osteoporosis is an important risk factor for the development of the disease, particularly if there is a maternal history of osteoporosis. Certain hormones and drugs are also known to have an important role in the development of osteoporosis. Estrogen has an important role in regulating bone remodeling. Although the precise mechanism is unknown, it is clear that estrogen has an inhibitory effect on bone resorption. Estrogen also increases levels of 1,25-dihydroxycholecalciferol, the active form of vitamin D, which in turn increases calcium absorption in the gut. Following menopause, the regulatory effect of estrogen on bone resorption is lost. Estrogen deficiency leads to increased osteoclastic activity and rapid loss of bone, particularly in the first 5 years after menopause. Androgens stimulate bone formation. Androgen deficiency occurs in both genders following normal aging and is thought to contribute to bone loss. In contrast, glucocorticoids affect the synthesis of bone by directly impairing the function and differentiation of osteoblasts, as well as accelerating their apoptosis. Glucocorticoids may also cause increased bone resorption due to their effects on the concentration of various hormones, including sex steroids. For this reason, people undergoing chronic treatment with corticosteroids are at risk for developing osteoporosis and have a high incidence of fractures. Smoking is known to cause a 5 to 10% decrease in bone density in both men and women, and has been shown to precipitate early menopause. Pathologic findings in osteoporosis include: in all forms of osteoporosis, mineralization of bone remains normal, in contrast to osteomalacia, in which defective mineralization leads to bone loss. In osteoporosis, there is greater loss of trabecular or spongy bone, which is found on the epiphysis, at the ends of long bone and in the vertebrae. Cortical bone, which is found on the outer aspect of bone and in the diaphysis of long bones, appears thinner and has increased porosity. There are decreased bony spicules, which are deposits of bone matrix aggregates that indicate bone synthesis. The bony spicules that are present appear thinner than normal in osteoporotic bone. Let's discuss the diagnosis of osteoporosis as our third learning objective. The diagnosis of osteoporosis is often made following bone fracture, which is why early screening for the disease is essential in people at risk. Bone fractures are often the first clinical manifestation of osteoporosis and present with acute pain, sometimes in the absence of trauma or underlying pathologies. Vertebral fractures, also known as compression fractures, are the most common overall. Loss of height due to fractures of the vertebral bodies, as well as spinal deformities such as kyphosis, are often seen. 1/3 of vertebral fractures don't manifest clinically. Fractures of the distal radius, or Colles fracture, and vertebral compression fractures are the most common in osteoporosis type 1, which is the postmenopausal type. Hip and vertebral fractures are the most common in osteoporosis type 2, the senile type. The workup of osteoporosis includes a complete blood count, measurement of serum calcium, phosphate, and vitamin D, and thyroid-stimulating hormone levels. Alkaline phosphatase should be measured in order to exclude conditions of bone breakdown, such as multiple myeloma. A 24-hour urinary calcium level is useful to determine the presence of hypercalciuria. Levels of PTH indicate if there is hyperfunction of the parathyroid glands. If androgen deficiency is suspected, levels of testosterone should be measured. All of these tests are usually normal in primary forms of osteoporosis and are done in order to rule out possible underlying etiologies. The diagnosis of osteoporosis is established by performing a dual energy X-ray absorptiometry, or DEXA. This study is used to calculate bone density at the hip and spine, which are at the highest risk of fracture. DEXA scan results are reported as a T-score. A T-score greater or equal to 2.5 standard deviations below the mean indicates osteoporosis. Let's review the treatment and prevention of osteoporosis as our fourth learning objective. Medications used in the treatment of osteoporosis include bisphosphonates, such as alendronate and risindronate. Bisphosphonates are the first-line therapy for osteoporosis. They act by inhibiting osteoclastic activity, thereby decreasing bone resorption. Other first-line drugs include selective estrogen receptor modulators, or SERMs, such as raloxifene. SERMs act by binding to estrogen receptors in selective tissues. Raloxifene acts as an estrogen agonist in bone tissue, thereby increasing bone density and reducing the risk of fractures. Raloxifene acts as an estrogen antagonist in breast and endometrial tissue, thereby limiting the scope of its actions to bone tissue and making it ideal for the treatment of osteoporosis. By contrast, tamoxifen, another SERM, also acts as an estrogen agonist in bone, but its use in the treatment of osteoporosis is not indicated because of its agonist effects on endometrial tissue and the increased risk of endometrial cancer in susceptible women. Because of its antagonistic actions in estrogen receptors found in breast tissue, tamoxifen is indicated in the treatment of hormone-positive breast cancer. As described previously, calcitonin is a hormone that interferes in bone metabolism by directly binding to osteoclasts and inhibiting bone resorption. Although it is approved for the treatment of osteoporosis, calcitonin has a much lower efficacy when compared to bisphosphonates and SERMs, and is therefore not considered first-line therapy. Studies have shown that the use of calcitonin decreases bone pain following a fracture secondary to osteoporosis, but the mechanism behind this effect is unknown. Teriparatide is a recombinant form of PTH. Although in calcium deficiency, PTH stimulates the breakdown of bone, when given intermittently, it acts on osteoblasts rather than osteoclasts. In this way, it stimulates the formation of new bone, thus increasing bone density. Teriparatide is approved for use in postmenopausal osteoporosis and hypogonadal osteoporosis in men. Other modalities in the treatment of osteoporosis include calcium and vitamin D supplementation. An adequate intake of calcium and vitamin D is necessary in order to maintain body stores and protect bone. Physical therapy, including early mobilization, is recommended once a fracture has occurred. The drugs used in the treatment of osteoporosis are also used in its prevention in order to minimize bone density loss. In addition, the prevention of osteoporosis includes lifestyle modifications and screening for early detection. Lifestyle modifications such as smoking cessation and reduced alcohol consumption are recommended in order to prevent bone loss. Weight-bearing exercise is recommended because it increases bone density and has an added benefit if initiated at an age before peak bone density is reached. It is recommended that all women 65 years or older undergo testing of bone density by DEXA scan. In women with increased risk of developing osteoporosis, measurement of bone density is recommended at the age of 60. Although osteopenia can be evident on plain X-ray film, its use as a screening method for osteoporosis is not recommended because more than 30% of bone must be lost before changes become apparent on film. Let's return to our vignette and apply what we've just discussed. Given this 66-year-old female's presentation of a hip fracture with a likely positive family history of osteoporosis and other risk factors such as smoking and low body weight, she probably has primary osteoporosis type 1, also known as postmenopausal osteoporosis. Now, what is the best screening method for this patient's underlying condition? The best way to screen for osteoporosis is by assessing bone density. This is done through dual energy X-ray absorptiometry, or DEXA scan. DEXA scan results are reported as a T-score. A T-score greater or equal to 2.5 standard deviations below the mean indicates osteoporosis.